Okay, hello everyone. We're at the top of the hour, 8 a.m. Pacific. So we'll go ahead and get started. I'll just start with a brief introduction. So my name is Ben Adam. I'm a pathologist at the University of Alberta in Edmonton, Canada. And on behalf of the Renal Pathology Society, it's my pleasure to welcome you to another edition of this collaborative seminar series between the RPS and GlomCon. Focused on nephropathology and the opportunity to chat with some of the experts in the field with on some of the topics that are emerging and controversial in our area. And today, it's my great pleasure to introduce our speaker, Dr. Professor Parmjeet Randhawa. He doesn't need an introduction, I think, for most of you, but he is a professor of transplantation pathology and director of the Transplantation Pathology Fellowship Program at the Thomas E. Starzl Transplant Institute at the University of Pittsburgh School of Medicine. He's internationally known as a transplant pathologist with numerous contributions to the Banff schema for renal allograft pathology. His work has helped better define several diseases of the transplanted kidney, including BK virus nephropathy, PTLD, CMV infections, T-cell mediated rejection, and chronic active TCMR. And much of his work is reflected in book chapters contributed to Heptonstall's classic textbook on the pathology of the kidney. He's past president of the Renal Pathology Society. He's received several awards, including the Jacob Chirg Award from the RPS, as well as the American Society of Transplantation Established Investigator Award. He's been awarded over $5 million in NIH funding over the course of his career and has over 440 publications in Web of Science. So a true expert in the field, and it's our great privilege to have him with us here today to talk about transplant molecular diagnostics, cutting through the hype and promoting objectivity. Thanks again, Parmjeet, for being here with us today, and I'll hand it over to you.
Yeah, thank you, Adam. It's a real pleasure and honor to be a speaker on this series, which has been on my Sunday morning calendar ever since I discovered this gem of an educational tool about a year ago. I try never to skip it, although there are times I have to do multitasking, such as doing it at the same time as tying my turban before going to a social event. All right, so I don't have any relevant disclosures. And here's an outline of my talk. This is a transplant kidney task. And it's the glomerulus and also the nephron distal to it. I think I like the idea that the GlomCon takes a liberal view of what a glomerulus is. And I will begin with strengths and limitations of mRNA-based diagnostics and its applications to evaluation of kidney graft dysfunction. There's a lot of lingo I'll be using since not all of you are transplanters. Let me say ABMR means antibody-mediated rejection. BL is borderline changes, suspicious for acute rejection. TCMR is acute T-cell mediated rejection. And CA-TCMR is chronic active TCMR. The V lesion is intimal arteritis. And the ATI is acute tubular injury. So there are a lot of technical approaches to mRNA diagnostics. There's multiplex RT-PCR, there's RNA-seq, there's nanostring. Then there's DNA microarray technology, especially the MMDX system, the molecular microscope, invented by Dr. Halloran. Most of the literature in the area is actually, MMDX based. So you'll find me quoting a lot of data from those investigators, and I will use that data primarily for illustrative purposes. So let me put this idea of molecular diagnostics in perspective. As we know, reaching a clinical diagnosis is a systematic process. We have to take the history, the physical exam, the labs, radiology. And similarly, reaching a pathologic diagnosis must also be a hierarchical process. A gross evaluation must be a key first step. If we do not slice an organ thinly, do not visualize an infarct, and do not make sure that it's sampled, well, no histologic or molecular diagnosis is going to give you the correct diagnosis. So the light microscopy extends our gross vision to about a micron. Electron microscopy extends it to about 1 nanometers. And the lower down you go, the more critical the sampling becomes as to what you're looking at and to put it in context. Immunohistochemistry allows identification of specific proteins. And then transcriptomics adds the very important spectrum of molecular features, which, however, must always be correlated with other features. So I put transcriptomics at the bottom because that's where it belongs. It has to be correlated with everything else that goes beyond it. And I have to stress there are some indispensable strengths of histologic examination, which we tend to forget. It provides structural context to the molecular findings. It allows the gross topographic regions affected to be specified. For example, in the capsule, we might attribute the inflammation to surgery. Cortex would be rejection. Medulla might be pyelonephritis. Then histology localizes the disease to specific microcompartments. In the glomeruli, we can make diagnosis of FSGS. In the tubules, BKV nephropathy, interstitium, drug-induced nephritis, and then a whole lot of vasculitic disorders when we examine the vessels. The cell type affected is identified, which is important. For example, you can say proximal tubular vascularization is important for diagnosing cyclosporin or tacrolimus toxicity. And then electron microscopy allows you to examine the subcellular organelles, such as, for example, dysmorphic mitochondria inside of a very toxicity. And the histology particularly has some additional relevance to transplant pathology. It provides a quick turnaround time in most major medical centers, as little as 5 hours. It can identify diseases with non-viable tissue, which cannot be probed by transcriptomics. It can recognize metabolically silent scars, which again may or may not have any RNA. It allows visualization of rare lesions, such as intimal arteritis, which may affect only 1 out of 10 vessels. And it can permit use of ancillary techniques, such as stains for fungi and polarization for quantifying serious red. And of course, there are many, many advantages of mRNA profiling. It interrogates biopsy at the molecular level. It will let you see biochemical changes which cannot be seen at light microscopy. It can define tissue injury, repair, development of tolerance. You have diagnostic and prognostic classifiers based on thousands of reads. And it offers unparalleled mechanistic insights into the pathogenesis of disease. And to quote just one example, we now know how important NK cells and antibody-dependent cytotoxicity are in the pathogenesis of antibody-mediated rejection. There are well-known problems in histology. I'm not there to deny them. Readings subject to histologic noise, low inter-observer agreement, applications of arbitrary rules, ambiguity of readings, the notorious borderline category, imprecise semi-quantitative grades, 0, 1, 2, 3. So molecular diagnostics is an important step forward, but there are significant limitations that remain, and they are insufficiently acknowledged. I like to refer to them as MDX hype, and which is the term I have included into the title of today's talk, just to better characterize its content. So the first I want to cover is molecular noise, by which I mean differences in gene expression signal within the same diagnosis. There are biological, technical, and let me get a pointer on here. So there are biological, technical, and bioinformatics variables. This is a long list. I'll just mention a few things. In biology, there's clinical heterogeneity within the same diagnostic label. In technical variables, we have RNA extraction, labeling, probe hybridization, and so on. And in bioinformatics, we have things like batch effects, data normalization, dimensionality reduction, and so on. All these affect the gene expression signal, and all these will thereby affect the class assignment of biopsies to specific categories. And just to give you an example, here are the variations in machine learning output for 10, 12 different classifiers. The x-axis, this is again Dr. Halloran's work. The average AUC in test sets, which were distinguishing ABMR from TCMR. The y-axis shows the average correlations in test sets. And you can see for TCMR, the correlations vary from 0.4 to 0.9. It is somewhat similar to a pathologist calling fibrosis moderate and another pathologist calling it severe. You can take means, but that doesn't necessarily be the ground truth. It's an approximation of the ground truth. And the other thing I want to comment on is that inter-observer agreement amongst molecular diagnostic experts is quoted as greater than 90%. based on intra-class correlations of 0.99 and even 1.0. And assertions are made such as 99% accuracy. But these are all derived from the last step of translating the gene expression signal to the class assignment. All these steps before that, the upstream steps, if you recognize those, misclassification rates in the oncology literature are 27 to 49%, and Rex Smith, who is on the call, has also shown the same thing. Fairly wide discrepancies, which are purely due to bioinformatics techniques. And the discrepancy rates are even higher amongst MMDX experts when you go for the gray zone cases. For example, probable TCMR, which is the borderline category, expert 1 and expert 2 differed 38% of the time. Probable ABMR, which is suspicious of antibody rejection, expert 1 and expert 2, the molecular experts, differed 50% of the time. And this data is not often highlighted. I mean, this is really from a supplementary table that I'm extracting. Most people just talk about the 90 and 99% values. Then there are precision issues. Claims of 99% are made based on correlation coefficients. Now, correlation should never be conflated with precision. And to illustrate that, I have created this actually hypothetical tabla. We have data sets 1, 2, 3, 4, 5, and gene expressions 1 through 10. And they are very well correlating. The correlation coefficient is 0.99. But if you look at the standard deviation of these measurements, they are like in the 80% to 90% range, which should be considered unacceptable in any lab diagnostic application. And then the most frequent data quoted for the precision of biological reproducibility of MMDX is based on 37 biopsies. And these are replicate assays. And many of them do bunch together. The replicates bunch up together nicely below the threshold. And this is the one that's usually emphasized. But then there are a proportion of samples where there's significant variation between the duplicates. And this variation is actually 2 to 3-fold, which is again not a new observation. People who have been dealing with BKV PCRs and CMV PCRs know that 2 or 3-fold variation in molecular signals is common. Yeah, you can't get better than that. And also, these assays are based on 3mm biopsies, which are then, for replicate purposes, they are divided into smaller fragments. So I don't believe that this iterative mincing can capture the variation in full-length codes. And so let me make a few very broad and simple concepts as to how the precision of gene expression measurements will be further affected by sampling problems on top of everything else that I've said. And of course, sampling also affects histology, but histology samples are 1.5 centimeters, and that's a potentially 5-fold increase from the MMDX samples, which are 3mm. And some people actually claim this 3mm ability to be a virtue of MMDX, but you can also consider it a limitation of MMDX. It's really your perspective. So let's look at this donor kidney, which has an infarct at this end. So obviously, if you take a sample from here, you're not going to get viable RNA. Taken from here, you'll get severe ischemic injury. From here, you may not get any injury, and there'll be a whole gradation as you take the sample from this severe involvement to no involvement. And an argument is commonly made, oh no, molecular diagnostics can detect diffusing molecules. Well, the diffusion will be affected by the serious drop in concentration as you go away from the main lesion. And concentration is certainly a very important part of the machine learning classifier class assignment process. So now let me go to the microscopic level sampling issues. In a kidney biopsy conference that I take every week, about 20% of the biopsies are dramatically different. One core might look like this with no inflammation. One core may have severe inflammation and fibrosis. In other biopsies, again, about 10 or 20% of the time, you have fibrocollagenous tissue, you have skeletal muscle, you have skin. So if you take a blind piece, such as for MMDX analysis, in a small proportion of cases, you may not even have, kidney tissue. And the focal distribution of lesions definitely results in different gene expression profiles. Since MMDX sales rep would continuously challenge me on this, I decided to just do a study. So I took 5 transplant biopsies, which had focal inflammation and tubulitis, which was varying along the length. So I took an area A, which had no inflammation. I took an area B, which had inflammation. And within the area inflammation, I created some replicates to see how reproducible that is. And in these experiments, these are all formed in fixed tissue experiments, RNA-seq. I was able to get 11 to 18 million Illumina reads for every region of interest. Let's see, I can't move it. It's stuck for some reason. Any suggestions? Oh yeah, I see a hourglass sign. Something is happening. And I am in my office where the internet connection is usually pretty good. So I hope this doesn't turn out to be a problem. Oh yeah, okay.
Oh, there you go. Yeah.
So when you compare 2 different regions of expression within the same biopsy, you can get lots of differentially expressed genes, like 77 to 1100. When you analyze the replicates, the number of differential gene expression was much smaller, from 1 to 9. And then if you do the principal component analysis, you see what you expect. The duplicates, they cluster together, the B1 and the B2 subregions, but they do cluster away from the A when you decide to compare A and B. So this basically tells you that, yeah, you can have biopsies. If you send one MMDX, one end for MMDX, you will get no TCMR. If you send from the other end, you will get TCMR. And this, of course, happens in maybe about 20% of the biopsies. And this process will not affect diffuse diseases like acute tubular injury or advanced antibody-mediated rejection, but it seriously will affect TCMR. And as the data I will show you, that's what we see actually. So let's go on to discussion of individual diseases. And the first one is ABMR, for which there are well-accepted applications. And this is an area which has really benefit from molecular diagnostics. And I will quote a classical study again from the Halloran group. 65 ABMR biopsies, 48 were C40 negative, then compared with others, including mixed rejection, TCMR, and possible antibody. And then an LDA-based classifier was made, which had an output score of 0 to 1. Now, a score of 0.2 was accepted as molecular ABMR threshold so that they could achieve 90% specificity of the diagnosis with a histologic ABMR in the training set. So you note this important point. MMDX was designed to agree with histology. So the subsequent drop in performance that we have seen is actually, I would argue, quite common. It's there in all biomarkers. They perform very well when you develop them. When you got in the real world, they don't do that as well. And another issue, an important issue in my opinion, is that the MMDX was standardized on full biopsy codes. When they went into the real world, nobody would give them full biopsy codes. So when you reduce it to 3 millimeters, at the very least, you are obliged to re-standardize your paradigms. And to my knowledge, that's not done. So that's one of the reasons, I think, for the drop in its performance. And so the pathology parameters that were used for training were reasonable. G greater than 0, PTC greater than 1, CG were all acceptable. But of course, none of them is perfect. We know there are problems, but that's the best you can do. And the C4D could be 0, 1, 2, or 3 if DSF is positive. And the intra-observer discrements for scoring G and CG, as we know, are in the 35 to 45% range for low-grade lesions. So these classifiers have been benchmarked against a very low reproducibility lesion. So the errors of histology get carried over into these molecular tests, and obviously they will affect the ultimate performance, which they are. And so here is a distribution of molecular ABMR scores in the INTERCOM 300 study. If this was the threshold, yes, the test was pretty good. Most C4D positive and most C4D negative ABMRs could be recognized. The recognition of C4D negative ABMR has been a major advance, which has resulted from the molecular technology. But you would also note that about 1/3 of the cases down here, which are histologic ABMR, are not recognized by histology. And of course, certainly many of these cases may be early forms of ABMR, which are not visible by light microscopy, but are visible by the molecular techniques. But on the other hand, we should recognize other things. For example, some of the C4D negative cases might be complement independent endothelial injury. The HLA negative, DSA negative cases may be HLA independent endothelial injury. So there's a lot of complexity to human disease. And so in summary, this is the a reasonable summary of how the ABMR classifiers perform. Specificity 87% and negative predictive value 94%. And as I said, 1/3 of cases which are not confirmed, they are histology positive but not confirmed in MMDX. The positive predictive value is about 50%. And yes, MMDX calls much more ABMR than histology calls. So the threshold is lower. But the important question is, what is the right threshold to select patients for rather serious therapies such as plasmapheresis, IVIG, retux? Histology may be too high, MMDX might be too low. So unless we do proper validation studies, we could easily end up not treating some patients and over treating some patients. And so that's an area which really needs a lot bit of more work. And the molecular tools, of course, allow us a pathway to get that information, but a lot of information that we need for patient management is still not there. And so I can emphatically state that mRNA profiling is not going to replace the biopsy diagnosis of ABMR. It can't tell you there's thrombosis, arthritis, transplant gonopathy, if there's 50% glomerular sclerosis, advanced IFTA. It will fail QC parameters if the tissue is largely infarcted. It may not generate enough signals if there's dense fibrosis, and there's not enough data to show that ABMR can be distinguished from its mimics, like MPGN, thrombotic angiopathy, or ANCA vasculitis. Yet, certainly, these molecular techniques can play a complementary role. For example, in evaluating biopsies of equivocal, G0 to Z1 or PTC 0 to 1 lesions, or if biopsies where the G and PTC sum score is 2 or 3, but the C4 is negative or minimal, we could use molecular diagnostics. We could use it if the C4 is positive and there's no histologic rejection. But as I mentioned, the diagnostic threshold should not be regarded as equivalent to a treatment threshold. And to make that case, I'll remind you that the clinical value of treating subclinical TCMR on protocol biopsies is still debated after so many years. So the desirability of treating subclinical and subhistologic molecular ABMR, well, that is going to need significant work too. And I predict that we are going to discover cases of borderline ABMR, which may not require any intervention, but just watching and waiting and see what happens. So another issue I want to discuss is that recent work actually has raised the question if C4D negative, DSA negative, MMDX positive, ABMR is always ABMR. Of course, the MMDX report will always call them ABMR. And some of it is, probably a small proportion is non-HLA antibody, but there's a lot of other stuff in kidney transplant biology. There's NK cell recognition of missing self, there's T cell mediated endothelial injury, there's plasma cell rich rejection, there's participation of innate immune systems such as macrophages. So we can't make the interpretation too simple. We want to be simple, but not too simple. So that's a fine line. So let's go on to borderline change. We all know that the reason it was created is to account for cases which do not meet the criteria for full-fledged TCMR. And there are many problems with this entity: difficulties in grading inflammation, imprecise threshold between I0 and I1, non-accounting of the density of inflammation, going only by percentage, and then a very wide range from 11 to 100% of inflammation is borderline. So obviously, the mRNA profiling has potential. We can quantify inflammation as a substitute for just going by I0, 1, 2, 3. We could potentially distinguish between quiescent and immunologically active infiltrates. We could perhaps distinguish inflammatory response to ischemic injury versus true alloimmunity. But again, there are just unbelievable and very disconcerting discrepancies between histology and molecular diagnosis. And this is Dr. Halloran's own work. A series of 1679 biopsies, different histologic diagnoses are plotted here, and the proportion confirmed by molecular are on this axis. And I'm just going to slice this part out, which corresponds to the borderline. And basically, 56% and another series up to 70% of histologic borderline is no molecular TCMR. Some of it is sampling issues, but the two other issues I want to discuss. One is the threshold problem, and one is issues with classifier development. So let's talk about this threshold problem. Supposing we have 50 biopsies and we all plot them on the x-axis, and the y-axis, we have two assays, let's say histology and molecular. And if, let's say, histology sets the threshold for a call along this dotted line, it might say, oh, 20 out of these 50 biopsies have borderline change. But let's say the molecular process sets the threshold here and then says everything below this is not rejection. We are only going to call this rejection. Well, then they will say only 7 of these 20 have rejection. So there is no inherent value to these thresholds. They are arbitrary. So what we have to do is to see which threshold corresponds to a clinically meaningful outcome. And that has not yet been systematically done. And so here are some of the conceptual issues that I see with applying the TCMR classifier to borderline biopsies. The TCMR classifier was taught not to call borderline biopsies as rejection. So I would argue this is circular reasoning to say that, oh, borderline biopsies are not TCMR. And yet, why are only 70% of borderlines being called not TCMR? That number should really be 100%. So you could argue that the performance of the borderline classifier in the assay development phase is not really matching its subsequent performing in the real world. And that's the heterogeneity of borderline. So these tests cannot be as accurate as you claim them to be. Now, how should we resolve these discrepancies? I guess one obvious way is to clinically follow up histological borderline and molecular diagnostic no rejection biopsies. We follow them up and see what happens. Unfortunately, this is not an easy question to answer. Many such biopsies show no progression on short term. This is well known and should not be argued as saying, oh, this is added value of MMDX to histology. We said it's no rejection, and yeah, they don't progress. Well, if you look at the literature at large, borderlines progress to 1A or more, depending on the series, as little as 30 to as high as 70%. Some biopsies with just I0T1 go on to develop ABMR. The progression rate of MMDX negative borderline in one series that I had the opportunity to examine was about 30%. So they can say, oh, we were right 70% of the time, but 30% of the time you couldn't pick it up. So it's a mixed picture. And I'm certain that as you examine more series, this number will not remain 30%. It might get closer to the other numbers. It will vary depending on how you select your cases of borderline. So let's move on to definitive TCMR, that is biopsies above the threshold of borderline. So here's the performance of the molecular microscope classifier. The sensitivity is just 50%. Positive predictive value 60%, negative predictive value is good, but similar to a pathology saying there's no rejection. The overall accuracy would look good. It's 89%, but it's driven largely by a high negative predictive value. And again, the discrepancies are very disconcerting. 40% of histologic TCMR in this study and up to 50% in others cannot be confirmed by molecular diagnosis. It is highly unlikely, in my opinion, that these are all histologic misinterpretations. I mean, we have been calling rejections for 5 decades. During these calls, we have advanced the field. The rejection rate has gone down from 50% to 10%. Surely you can't argue they're all wrong. Yes, some of them are, but not all. So I believe, again, there is the sampling problem, there's the threshold effect, there's issues with classifier development. And one more factor I want to mention is it could be a relative decrease. The MMDX just calls more ABMR. Many things that pathologists call mixed TCMRs, it calls them ABMR. And many that we call chronic active TCMR, it flat out calls them ABMR. So there is an inherent bias in these two assays in what they call. And that bias is not justified by appropriate scientific data, in my opinion. So again, let's see how should we deal with histology positive and molecular negative cases. So there is limited data, which if you go to presentations organized by MMDX, they will show, yeah, we called it no rejection, nothing happened. On short term, there was no rapid deterioration. But that should not be interpreted as validation of MMDX. I have seen untreated 1As, untreated 1Bs in weaning trials. And nothing detectable happens in a few months or a year. I saw IFTA developing after 3 to 4 years. So I worked with tolerance investigators who were elated by their tolerance protocols and felt they had a very good regimen, but then their enthusiasm dampened as we followed up the patients. So these questions are difficult to answer. We should not prejudge to any conclusion. They'll be very difficult to answer. If you ask me, the differences will be much more modest than you think they're going to be between MMDX and TCMR histology. So let me discuss now the role of MMDX in mixed TCMR and ABMR. So there's one huge attractive advantage of MMDX. You can give separate ABMR and TCMR classifier scores. However, the diagnosis is still confounded by the low sensitivity of MMDX for TCMR. According to MMDX series, estimates of mixed TCMR are in the 5 to 10% range. If you talk to pathologists, their estimates are as high as 63%. That's 1A and above, even higher if it's borderline. I can tell you that at Pittsburgh, 90% of cases that meet the criteria of ABMR have so much inflammation and tubulitis that we treat them as mixed. We believe they have T cells, which are associated with tubular injury and apoptosis and dropout. And I'm aware of the counter opinion that they think that T cells are a secondary process, but it doesn't really matter whether primary or secondary. If they're there and associated with damage, we've got to do something about them. There is no T cell treatment. I mean, there's no ABMR treatment that's well established. TCMR, we have methods, so we should try to treat them. And so what would be the path forward to resolve these disparate viewpoints? Again, we need a clinical trial. And one trial I would suggest is for the INTERCOM investigators to show that only the 5 or 10% cases they call mixed need T cell treatment. I think that would be a very tall order. If you were to do such a trial, the truth will be somewhere between 10% and 63%. So the idea of a mixed rejection is very fuzzy. It needs to be better defined. So let's talk of chronic active TCMR. Let me not go into the Banff criteria. I will just illustrate that there are biopsies which have extensive fibrosis and tubular atrophy. And if they have inflammation and tubulitis, which is in the non-atrophic tubules, we call it chronic active TCMR 1A or 1B. And we do, of course, require that these cases be C4D negative and DSA negative. And we also require that by clinical pathologic correlation, you reasonably exclude other things such as pyelonephritis, BKVN nephropathy, obstruction, and so on. So recently, we sent 5 chronic active TCMRs for MMDX analysis. All 5 had pretty high scores for acute kidney injury, atrophy, fibrosis, global disturbances. But all 5 were said to be no TCMR or they had a very low score. And all cases were given a resounding diagnosis of ABMR, which I think in 2 or 3 cases we could support with a positive DSA and C4D. And the other cases we could not support it. And some of these cases had been measured for DSA multiple times, like in some cases 5 times or more. And one of these cases actually even responded quite well to anti-thymocyte globulin. And now the other problem I noticed when I reviewed these reports, that all of these cases had actually T3 tubulitis, but the tubulitis probability score was typically normal or very, very low. And I could say the same thing about tubular atrophy. There were cases with severe tubular atrophy, and the tubular atrophy score was close to the normal range in some cases. And again, I think that's not unexpected. Fibrosis is patchy, so if you don't take the fibrotic part and MMDX, of course, you're going to get a low score. And the same problem is how with the arterial hyalinosis. These are small numbers, but they're also reproduced by larger series published very recently by Gaurav Gupta. Most cases do well, but if you go for the higher scores, a substantial number have a very wide range of scores from close to 0 to close to 0.9. And so the discrepancy between histology and MMDX that I saw in my 5 cases is very well described by Dr. Halloran. Here's the paper, which is titled Molecular Phenotype of Kidney Transplant Indication Biopsies with Inflammation in Scarred Areas. And the abstract reads in part, we conclude that IFTA reflects recent ongoing parenchymal injury, often with concomitant ABMR, but few with TCMR. I would like to argue that this conclusion is not a biological ground truth, but it's the expected result of how, if you use a classifier developed in non-scarred TCMRs, if you use it to probe scarred biopsies, well, the results are not going to be the same. In fact, I would say that those genes will get diluted by those genes which are overexpressed in fibrogenesis, tubular atrophy, arteriosclerosis, tissue remodeling, and so on. And so the molecular classifier is really calling mixed rejection as the only ABMR, the chronic active TCMR is the only ABMR. So the role of TCMR is being discounted. And I would use this as an example of how the output of machine learning curves can really reflect the personal opinion of the trainer. And it can masquerade as an objective truth based on molecular analysis, but it's really how you interpret these biopsies. You could interpret it as ABMR with secondary influx. You could interpret them as ABMR plus TCMR, and nobody knows which opinion is the more correct one. So I would like to share with you some data on the treatment of what pathologists call chronic active TCMR. In a Banff survey, 41% of nephrologists actually treat it routinely, and 30% treat it only if there's not severe IFTA, and the treatment is typically steroid pulses and optimization of immunosuppression. In Pittsburgh, only about 28% show complete remission, 33% show partial remission, 40% show no remission. And the benefits of this treatment for graft term longevity, of course, we don't know. They need long-term follow-up. Many of these biopsies don't get a repeat biopsies. But MMDX suggests that the majority should not be treated as TCMR, and all should get treatment as ABMR, even if they're C4D negative and DSA negative. They have severe inflammation, severe tubulitis. MMDX interpretation is no TCMR, all ABMR. And that interpretation, at least to the group I work with, is very difficult to accept. It's very difficult for us to see blue biopsies, inflammation and tubulitis, and say, we are not going to even try to suppress that inflammation, because all this inflammation is secondary to antibody. In many cases, there's no C4D, there's no DSA. So that's a difficult concept for us to grasp. So let's talk about V lesions or intimal arteritis. To give you a background, these can occur in ABMR or TCMR or mixed. And the response to anti-rejection treatment for grade 2A is 50 to 80% complete remission. For grade 2B is 10%. The death-sensitive graft survival, only 69% of grafts have grade 2A function at 8 years, and 46% of grafts grade 2B to 3 do so. So you can see that grade 2 biopsies are heterogeneous, and their remission rates actually overlap with 1A and 1B. So what we call 2A doesn't always do as badly as you think, because in many cases, just 1 RT out of 10. There's arteritis, there's not much inflammation and tubulitis. So that again shows the heterogeneity of pathology in human disease. And then the clinical outcome, of course, varies by the type of arteritis you're saying. This is in a French series from Paris. TCM arteritis had 15% graft loss for 6 years compared to 2% in controls. Then there was, in my opinion, an unspecified number of cases which have impending graft loss. I mean, they're not graft loss, but their GFR is low and they're just hanging in there. And ABM arteritis rate of graft loss is 60%. But we have to remember that 60% of these arteritis cases, if you look for the inflammation, it's there in the form of T cells. And the Paris group actually admitted that 2/3 of the biopsies of what they had ABMR had inflammation and tubulitis scores of more than 3. So they also agree with the concept that a lot of ABMR called by MMDX is really mixed ABMR and TCMR. And of course, these insights can only be generated if you have pathology. If you grind up the tissue and take an RNA slurry, then all this information is lost. And so here are some MMDX findings in V lesions, again from the Halloran group. So amongst 30 cases of TCMR, 50% had a score which is considered rejection. For biopsies with ITV lesions, it was 95%. 17% of them had scores greater than ABMR threshold of 0.2. Half were DSA negative. C4D status was not presented in that article. For the isolated V lesions, mostly more than 1 year, 46% had ABMR scores of greater than 0.2, but they certainly did not behave as ABMR. So the molecular diagnostic score, the meaning of this high score in the setting of isolated intimal arteritis needs some validation, because we can't obviously be treating stable patients with plasmapheresis or IVIG. And then amongst the no molecular rejection, 33% of the TCMR cases were called no molecular rejection by borderline. And so let me now make a few comments about the application of the MMDX classifier to V lesions. The molecular classifier for TCMR was developed based on biopsies like this: severe inflammation and tubulitis. If you take biopsies like this isolated V lesion where 1 artery out of 10 has a few inflammatory cells, and there's no inflammation or tubulitis to speak of rest of the time, well, of course, I mean, the classifier is going to give you a very different result. And so to me, this is again circular reasoning. You saying this isolated V1 is not TCMR because my classifier says it's not. Well, the classifier didn't actually include any cases like this. So how can you make that judgment? And I would also argue that the piece taken for MMDX in many of these studies was probably normal. So it probably didn't have this isolated V lesion. So I can make a few additional points. MMDX is not sensitive to the presence of rare lesions. Probe signals with the least variation are actually removed during the normalization process. So this creates a bias for the detection of only major transcriptional disturbances. So another issue I want to address is the diagnosis of rejection in the medulla. MMDX presentations assert their ability to do so as an advantage over histology. Well, of course, pathologists can diagnose rejection in the medulla. They are just more cautious. They don't want to confuse it with nephropathy, drug-induced interstitial nephritis. MMDX hasn't even profiled these diseases. So how can it claim, that it can even distinguish them? In fact, it doesn't make any attempt to do so. And I have personally experienced MMDX false positive diagnosis of rejection in pyelonephritis as well as granulomatous disease. And here are some examples. I mean, if you want to see rejection outside of the cortex, here you can see this is medulla, severe tubulitis, and this is severe peritubular capillaritis. This is ureter with the T cells infiltrating the urothelium as they would infiltrate the tubules. This is actually the pelvic calyceal urothelium. This is the ureter. The C4D is positive in the subepithelial capillaries. And even if you look at the adipose tissue, yeah, they have really activated T cell infiltrate. So if the adipose tissue is derived from the donor, of course, it's going to reject. And so the two other points I want to make here is histologic scoring is not always necessary for making pathologic diagnosis. The BAMF recommends that you score only in the cortex, but that is only to make the scores, the disease severity, comparable from one center to another. Indeed, blind scoring without reference to the clinical context can give you wrong diagnosis. You can get peritubular capillaritis, for example, in BKVN nephropathy, or you can get low-grade arteritis in the case of thrombotic microangiopathies. So that brings me to molecular diagnosis of BKVN. Now, the distinction between the TCMR and BKVN is a vexing problem in clinical transplantation. As such, it was hoped that molecular methods would make this distinction easy. Unfortunately, most investigators who have examined this problem find that the gene expression profile of these two diseases is very similar. So let me again quote some classical studies from the Halloran group. They have the TCMR and the polyvorum nephropathy. This is the threshold for diagnosing TCMR. What's to be noticed here is that the 8 of 13 cases of BKV nephropathy had signals above the TCMR threshold. And these were interpreted to mean that most cases of polyoma nephropathy have a component of rejection, which may be even true at a biological level, but certainly it is not true at a clinical level. Most of these patients definitely do not respond if you give them steroids. That's well established. And most clinicians will tell you they made serious mistakes in the 90s and mistreated cases which ended up in the bucket. And now we have better graft survivals by ignoring the tubulitis, by ignoring the rejection-like signals, and just treating it like virus. And of course, the TCMR classifier never had any cases of polyoma nephropathy in the training phase. So again, the conclusions that you draw are a little bit, problematic to me. So now, most recently, a BKVN probability classifier has been developed based on MMDX technology. It is derived from training sets with unknown proportions of TCMR and BKVN related processes in the tissue. So in my opinion, I don't expect it to do well. I hope I'm wrong. And I hope somebody pulls me up 5 years from now. You said this, but we see this, but that's my prediction. I've been in this business for a long time. There's also a quantitative RT-PCR protocol available to measure VP2 mRNA biopsies. And they say this is going to help in the differential, but if you don't have a clinically relevant threshold, how are you going to use the information? If you make it too sensitive, you will see the viral RNA detected in people who do not need treatment. If you set it too high, you may not even detect in people who don't need treatment. So again, there's more work needed before any of these classifiers can be implemented in clinical practice. And another big problem in the field is there is still no classifier for what we call probable BKV nephropathy. These are cases of BKV viremia with no detectable virus in the biopsy, and the lack of detection is a sampling problem. Because we know if you take two cores and stain them, 40% of the time, only one of the pieces stains for virus. And that is now recognized by experts as presumptive nephropathy, and we treat them as such. And plasma TCR for practical purposes is still the way to go for treating most cases of BK viremia and BK nephropathy. And these classifiers are important investigative tools. I would like to see what data they generate, but they're not really ready for prime time. And so why is it so difficult to build a molecular classifier for BKV nephropathy? Well, BKV biopsies have a range of morphologic appearances: silent inclusions, acute tubular necrosis, severe interstitial nephritis, advanced tubular atrophy. To allow machine learning on this very wide spectrum, I would suspect you need a few hundred cases. And you will have to present all classes of disease with TCMR, without TCMR, with ABMR, without ABMR, with varying degrees of inflammation, atrophy, fibrosis. That is a very tall order. And so it's a very difficult problem to just say I've developed a classifier and say, well, I can do it. So let's talk about acute tubular injury. Pathologists are notorious at not being able to diagnose tubular level injury. Every few weeks, I see a case in my biopsy conference where there's rising creatinine, mild tubular dilatation, and I say, this is acute tubular injury. Then I see biopsies, which are protocol biopsies, done 3 months after transplantation. They have a stable creatinine. They show the same tubular dilatation. And many pathologists do not call them ATI. And some of these cases, we know the patients are not drinking enough water. So maybe this is subclinical ADI. If you can have subclinical ABMR and subclinical TCMR, why not subclinical ADI? So this is an area where mRNA profiling would actually benefit from tubular injury markers. But again, this requires very difficult to do studies in clinical medicine. Somebody will have to really go into input and output analysis of the patients that you recruit. And that work should be done, hasn't been done so far. And then there are implications similarly for donor biopsies, but in the interest of time, I will skip them. You can classify cases into donor-derived disease, living donors and deceased donors, and them on the clusters, they correlate with delayed graft function, but I will just leave it at that. So let me just summarize my talk so we can leave some time for discussion. So the mRNA profiling can absolutely enhance histologic diagnostics. Some examples of this are C4d negative ABMR, DSA negative ABMR, acute tubular injury, donor biopsies. I will repeat what you can accomplish only by molecular level analysis, biochemical changes seen not by light microscopy, diagnostic prognostic classifiers based on thousands of reads, predicting outcomes beyond clinical parameters and beyond histologic parameters, and providing mechanistic insights. These are all very appropriate uses of molecular technology. I look forward to how the field develops. My main problem is that we do not recognize the problems. So I'm going to list them here and leave it for discussion. MMDX results can be misleading if there's focal disease. The marketing is aggressive. There are hyperbolic claims, 99% precision, exaggerated superiority over existing diagnostic and prognostic tools. So we have to learn to judge the literature with critical evaluation. We have to recognize what's an opinion and what's a rigorous conclusion. We must note where we see a leap of logic, where we see a circular reasoning, and where we see a real transition of thought which makes sense. Molecular signatures of many diseases remain to be thoroughly studied, include all of these other allographs: diabetic nephropathy, glomerulonephritis, calcineurin toxicity, thrombotic microangiopathy. So I cannot consider the currently proposed applications of MMDX to be standard of care. I hope we get to that point. I would like to stimulate and encourage studies which get us there, but I don't think we are there. So I am open to now discussion and questions and criticism.
Okay, thank you very much, Parmjeet. Yeah, that was a great summary of, I think, the issues that a lot of us are.
Slide I forgot.
Oh,
I was the president of the Renal Pathology Society. They asked me to promote renal pathology. So this picture is included in my talk for that reason.
Great, thanks, Parmjeet. Okay, so we do have a couple. We have one question in the chat and one person with their hand up. Dr. Glassick asked his question first, so I'll maybe go to his, address his first and then go to Dr. Fowler next. So Dr. Glassick asked, do signals exist in MMDX that are reliably predictive of later evolution of distinctly progressive kidney fibrosis detected by serial biopsy histologic examination?
I believe the Halloran group has good classifiers. That's an actual illustration of what this technology can do. You can leverage the results of thousands of genes as opposed to just 20 or 30 different histologic parameters. And so, yes, it has been done. And yes, those tools are there. But unfortunately, I guess the clinicians don't use them because just saying that this graph is going to get lost 2 years earlier than another one doesn't translate into an actionable plan of therapy. So that is the problem. The tools are there.
Yeah, I agree. Okay, Dr. Fowler, I think you are unmuted. If you'd like to go ahead and make your comment or ask your question, please.
Yeah, just to clarify, I'm not a physician, so.
Oh, sorry. Okay.
Oh, that's okay. But I first want to say thanks for the presentation today. I think it's very important. And full disclosure, I do have a consulting agreement with Natera. But my question is the renal pathology overall, are they engaging with these companies to share these concerns so that, like as you said, that the marketing is not taking, taking center stage versus what's really best for patient care? And I'm just curious to see how that dialogue is going. And thank you.
I have never been associated with any molecular diagnostic company. In fact, I'm irritated by the presentations they give in public. I think some of them are just misleading.
Have you provided that feedback?
Sorry,
as a renal pathology formally provide?
I'm sorry, it's breaking up. Ben, can you help me understand?
Formally provided that. Can you hear me? Okay.
I can.
It's
choppy, but please try again. Yes.
Okay. Yeah. So my question is that have you shared this feedback with the companies formally?
Well, I hope they're listening today. And I'm welcome to go and give a talks, whoever invites me. And maybe you can tell the companies, here's a guy who's willing to, speak against you. Do you want to listen to him? I will happily go there and get challenged.
Okay, thanks, Kevin and Parmjeet. Yeah, if anyone else has any questions, feel free to enter them in the chat or put up your hand. Yeah, I agree, Parmjeet. There's a lot of information.
Thank you.
Kevin, I'm not sure if you're done. You're chopping in and out a little bit, but yeah, there's a lot of info out there in the literature, and I think it is a bit overwhelming for people. And I don't think it's surprising, or we should completely blame the authors of these studies that their tone is maybe a bit more optimistic than some people think is ideal. But it's important, I think, to have a reality check.
Some of them, if I may say
so,
I didn't want to say that. Some of them have a derogatory description of pathologists. There are people who compare them to pigeons. I mean, that's not even professional. I mean, that's how bad it is, in my opinion.
Yeah. Okay, we don't have any more questions at this point. So the one thing I wanted to ask Parmjeet, so you focus mostly on MMDX in your talk today. I mean, obviously there are other platforms that are becoming available and more widely adopted in the field of transplantation, like RNA-seq and NanoString. Do you have any comments on like the critiques of those particular platforms that you want to?
I have a feeling that they will be subject to similar issues. So the bioinformatic issues are not going to be solved by changing the technology. Of course, the NanoString and the RNA-seq will have one potential advantage of reducing the sampling error. But of course, pathology has sampling error, so it will get reduced, but not eliminated. And the one comment about the nanostring is that it's, you should speak on it. You ask some questions and answer them because you know more about it than I do. And I think that it's a very nice initiative going on by the nanostring people. They're trying to standardize it across labs, which is a huge thing. MMDX has one lab in California, and we do not really know how another lab setting up this technology will actually even correspond to their results. I suspect the correspondence will be bad. But nanostring is at least making an attempt to go across several institutions and show the reproducibility and see where the field goes. But I do see problems. In fact, I've already reviewed experiments where by other people where I see that this is not a total solution, but we have to keep marching forward, identifying the problems and seeing how we can solve them.
Yeah, I completely agree. I don't think that the critique that you've provided today, I don't think is specific to MMDX.
So the RNA-seq,
oh yeah, go ahead.
So the nanostring has one slight disadvantage, although this may not anymore be a disadvantage. Like initially you could only probe 1,000 genes, but I think the DSP allows you to go to 16,000. So the RNA-seq, I believe, can give you much more genes. And importantly, both of these technologies are applicable to formalin-fixed paraffin embedded tissue, which is a huge advantage. For MMDX, the true value is only there in a small proportion of biopsies, but you have to plan to collect RNA on all of them. So the big advantage here is you just wait, rely on histology, see what happens. If there are unanswered questions, then you use the molecule on top of the histology. You're not obligated to take a piece right away and send it out, and the associated costs, which are substantial.
Yep, yeah, that's true. Okay, I'm a bit surprised that we don't have more comments or questions. I guess your arguments were convincing enough that nobody has any opposition to what you said, Parmjeet. So yeah, right. I guess that's good to see. So yeah, if there are no more questions, we'll end there today. Let everyone get on with their Sunday. Thanks again, Parmjeet, for the very thought-provoking discussion. Yeah, I really enjoyed it personally, and yeah, thanks again for doing this.
Thank you.
Okay, see you all next time. Bye for now.